ABG interpretation, case study, Aglan protocol. How to study ABG? 4 items. Number 1, listen carefully to the clinical history. Number 2, study the lab investigations, including the ABG chart. Number 3, look at this Aglan ABG table to fill in the spaces measured and calculated. Number 4, back to this Aglan ABG table to study pH, chloride items, bicarbonate items, oxygenation state of the lung, and ventilation state of the lung. Clinical history. Study of the clinical history will be important for 2 things. Number 1, to anticipate the pathophysiology. Number 2, to anticipate the sequelae of events. Anticipation of the pathophysiology, like what? If the patient is vomiting, is going to lose chloride, gain bicarbonate, to develop hypochloremic metabolic alkalosis. If the patient develops diarrhea, will lose bicarbonate, gain chloride, to develop hyperchloremic metabolic acidosis. If the patient develops diabetic ketoacidosis, bicarbonate will be consumed, so he will develop high anion gap metabolic acidosis. In a renal failure patient, bicarbonate will be consumed by the fixed acids to develop also high anion gap metabolic acidosis. Methyl intoxication will be associated with the formation of formic acid to consume bicarbonate to develop high anion gap metabolic acidosis. Stable congestive heart failure, the patient will have hyponatremia, maybe on diuretics like furosemide to develop hypokalemic metabolic alkalosis. Liver cirrhosis patient will have hyponatremia, hypoalbuminemia, hypokalemia, and develop metabolic alkalosis. Anticipation of the sequelae of events, like what? If the patient develops vomiting, then became shocked, vomiting will develop hypochloremic metabolic alkalosis, then shock will develop high anion gap metabolic acidosis. Lab investigations, you should study sodium, chloride, potassium, BUN, serum creatinine, random blood sugar, ketone bodies, and serum lactate. Then come to the ABG chart to study it, to see the values. For the calculations of the calculated items, don't forget these formulas, these equations. I collected it in the form of golden rule in these 4 slides. You should know it by heart. Number 3, look at the Aglan table and fill the spaces. These spaces are 2. Number 1, the measured items will be taken from the lab investigation and the ABG chart. Then the calculated items with these red arrows, you have to calculate it before starting the Aglan ABG table. Number 4, study Aglan table. This Aglan table, as I have mentioned before, is formed of measured values and calculated values. To start with, number 1, by the pH. Number 2, the chloride items. Chloride items, serum chloride, chloride sodium ratio, corrected bicarbonate, and strong ion difference. Number 3, bicarbonate items, serum bicarbonate, anion gap, buffer base, strong ion gap, base excess. Number 4, oxygenation state of the lung, FiO2, BO2, B arterial oxygen, pressure of oxygen of arterial oxygen, and alveolar arterial gradient. Number 5, ventilation state, the pressure of carbon dioxide and its relation to the pH and bicarbonate. To study the pH, for sure, see whether is it normal, acidemia, or alkalemia. Start studying the chloride atoms. Number 2, as I've mentioned before, serum chloride, chloride sodium ratio, anion gap, strong ion differences, and corrected bicarbonate. From these items and from these data, you will come to the diagnosis of the start diagnosis, start pathology, the first pathology. Number 3, studying bicarbonate items, serum bicarbonate, buffer base, phase excess, strong ion gap, and anion gap. This will give you the last or the second pathology and the second diagnosis. Number 4, the oxygenation state of the lung will be studied through studying FiO2 and BaO2, and you will come to the formula alveolar arterial gradient to diagnose the oxygenation state. Is it normal or hypoxic? Number 5, studying the ventilation state through studying the pressure of carbon dioxide correlated with bicarbonate and pH. See whether the patient is hypoventilated, hyperventilated, normoventilated, compensated, or not.
Case number 6. A 72-year-old man with a history of COPD presents to the hospital with alcoholic ketoacidosis. From the history, chronic obstructive pulmonary disease, is chronic respiratory failure, high pressure of carbon dioxide, high bicarbonate, close to normal pH. Developed ketoacidosis, alcoholic ketoacidosis. This is the second pathology. Look at the investigations. Sodium 136, potassium 5.1, serum chloride 85, pH 7.2, pressure of carbon dioxide 60, bicarbonate 25, BO2 75. Urine ketone bodies positive. This patient was on FiO2 30%. Let's come and discuss the Aglan Abg table. This is the pH of the patient, 7.2. When you look at the bicarbonate, it's normal. So the pH, this pH, in this state, the actual state, is due to hyperventilation, retention of carbon dioxide. This is 20 mm mercury over 40, or the normal. This results in this pH 7.2, because bicarbonate is normal. But this pH is not just like that, it's not so simple like that. There is some sort of pathology. We'll discuss later. The second item is chloride. Chloride hypochloremia 85. Chloride to sodium is 62%. Normally 74. So this is hypochloremia. And this hypochloremia, when you come to the corrected bicarbonate, or the previous carbonate in stable state 39. So this patient was stable state was having hypochloremic metabolic alkalosis. Strong ion differences is 51, more than 40. So this data say that this patient, COPD patient, in his stable state, he was having hypochloremic metabolic alkalosis. What happened? He developed starvation or alcoholic ketoacidosis. Fixed acids neutralized bicarbonate, so bicarbonate dropped from 39 to 25. This is the normal value. but it dropped from this value to that. So he developed metabolic acidosis. Metabolic acidosis toward an anion gap. It's high anion gap, metabolic acidosis. But the bicarbonate dropped from this high value to the normal. That's why we looked at buffer base is normal, but the strong ion difference gap is 10. This is the fixed acids. So this patient developed high anion gap metabolic acidosis with the presence of strong ion gap. Base excess or base deficit, bicarbonate is normal, so it is 0. No excess, no deficit. When you look at the previous state of the patient from these data, the patient was having COPD with hypochromic metabolic alkalosis, as I mentioned before. When you measure the anion gap in this state, it is normal. This is true. When you calculate this is the previous state, stable state bicarbonate. Expected partial pressure of carbon dioxide will be 82. What is the impact of this 82 over 40 and this 39 over 24 on the pH? This will be the pH. Same calculation. So this patient was in his stable state, his pH 7.35, partial pressure of carbon dioxide 82, bicarbonate 39, and this had the value is normal anion gap. And accordingly, the buffer base is high, and the base excess for sure it has base excess plus 15. But when he developed starvation, alcoholic ketoacidosis, he developed this high anion gap metabolic acidosis. So from this formula, you can say that this patient had hypochromic metabolic alkalosis and developed high anion gap metabolic acidosis. What are the oxygenation state of the patient? He was on FI230. We calculated alveolar pressure of oxygen 135. The measured arterial oxygen 75. Alveolar gradient is 60. This is high. This means that the patient is having some problem in the oxygenation of the lung. He has some problem of the lung oxygenation. Partial pressure of carbon dioxide 60. Sure, this is hyperventilation. So this patient had hypochromic metabolic alkalosis plus high anion gap metabolic acidosis plus hypoxemia plus hyperventilation respiratory acidosis. Thank you.